So picture this. It's 2 a.m. Your patient's flawless supraclavicular block just wore off, and they've gone from 0 pain to 10 out of 10 surgical pain instantly.
Oh man, yeah. That's the worst phone call to get.
Right. They're panicking, the ER is calling you, and your perfectly engineered hand reconstruction is suddenly, secondary to a massive pain management crisis. Welcome to our deep dive.
Glad to be here.
Today, our mission is exploring upper extremity anesthesia techniques and nerve blocks. And this is specifically tailored for you, the plastic surgery residents and attendings running these cases. We're moving beyond just the surgical dissection to master the absolute prerequisite for a successful hand case.
Exactly. I mean, it's all about getting the patient numb, keeping them safe, and optimizing your OR efficiency, right?
Yeah.
And moving from the proximal brachial plexus all the way down to the digital nerves.
Yeah, and driving this whole focus is a fundamental shift in how we approach these upper extremity cases. We prioritize regional anesthesia over general anesthesia because, well, the clinical outcomes are just objectively superior.
They really are. I mean, you bypass the whole cascade of postoperative nausea and vomiting. You maintain vastly greater cardiovascular stability.
You entirely avoid those hemodynamic swings of induction and emergence.
Right. And most importantly, you bypass the PACU bottleneck and get your patients home faster. General anesthesia definitely has its indications, but for the upper limb, regional is the gold standard.
It really is, which means the responsibility shifts directly to knowing the precise location of your needle tip and the exact pharmacology of your syringe.
Yeah, before we inject a single drop, we really have to talk about safety boundaries. The margin for error here can be razor thin.
Because we have to look at what happens when local anesthetic goes where it shouldn't, right? Starting at the microscopic level.
Exactly. So here's the key point regarding local tissue architecture. The perineum is this remarkably resilient anatomical barrier. It physically prevents high concentrations of local anesthetics from penetrating into those delicate intraneural structures, the fascicles.
Right, so direct neurotoxicity from the agent itself is actually incredibly rare.
Provided the injection remains extraneural. Yes. Think of the perineum not just as a wrapper, but like a highly pressurized, tough vascular graft.
Oh, that's a great analogy. It's like a tough surgical glove. It offers fantastic protection, but if you puncture it and inject into that closed space, you're in trouble.
Massive trouble. The pressure spikes immediately, and you've just caused irreversible ischemic and chemical damage.
And the immediate physiological response to that capsular violation is severe radiating pain, right?
That intense lightning bolt pain is your only reliable clinical alarm bell. And this highlights a massive, really dangerous pitfall we see clinically.
Injecting around peripheral nerves when the patient is under general anesthesia or, heavy, deep sedation.
Yes. In real life, if the patient can't scream or reflexively withdraw when your needle breaches the perineum, you are flying completely blind.
You've intentionally disconnected your primary warning system.
Exactly. If they're sedated to the point of being unresponsive, a high-pressure intraneural injection goes entirely unnoticed by the team. The case proceeds normally, and the disaster is only discovered hours later.
When they wake up with a permanent motor or sensory deficit, brutal. So you absolutely need the patient awake enough to give you real-time feedback.
You do, but avoiding mechanical nerve damage is really only the first hurdle. We also have to manage the pharmacokinetics of the injection to prevent elast.
Right, local anesthetic, systemic toxicity.
Yeah, systemic toxicity is entirely a function of how rapidly the plasma concentration of the anesthetic rises. This is usually secondary to an inadvertent direct intravascular injection or rapid absorption from highly vascular tissue beds.
And the central nervous system is the first to fail, right?
It is. CNS toxicity is strictly dose and time dependent. The early warning signs are subtle, but they're classic. You have to actively look for them.
Like asking the patient if they're experiencing tinnitus or a sudden metallic taste?
Exactly. Metallic taste, lightheadedness, or peripheral numbness. If you see any of those, you halt the injection instantly.
Because if plasma levels continue to climb, those inhibitory pathways in the brain get blocked first.
Right, leading to unopposed excitatory activity. This manifests rapidly as muscle twitching, tremors, tonic-clonic seizures, and eventually total CNS depression and respiratory arrest.
And when a seizure hits, the immediate pharmacological intervention is administering benzodiazepines to elevate the seizure threshold, along with airway protection, obviously.
Obviously. But while a seizing patient is terrifying, Cardiovascular toxicity is the truly lethal threat here.
Because it often presents suddenly, without that prolonged neurological prodrome.
Yeah, cardiovascular collapse happens because local anesthetics directly impair myocardial conduction. You'll see prolonged PR and QRS intervals on the monitor. That's the suppression of the SA and AV nodes.
Which degenerates into severe bradycardia, high-degree heart block, and a systole.
Right. And here's a crucial pharmacological reality you have to respect. Bupivacaine is vastly more cardiotoxic than lidocaine.
Because lidocaine binds to cardiac sodium channels but releases quickly during diastole.
Right, whereas bupivacaine is fast in, slow out. It binds tightly, accumulates rapidly with each heartbeat, and it simply does not let go.
So when you hit cardiovascular collapse from bupivacaine, standard resuscitation often just fails.
It does. The protocol requires immediate intubation, mechanical ventilation, and aggressive ACLS. And you immediately call for lipid emulsion therapy.
To create a pharmacological sink to pull the bupivacaine out of the myocardium.
Exactly. There's no waiting to see if their rhythm improves. You push the algorithms instantly.
Okay, so with those safety parameters established, let's talk about optimizing the chemistry of the block, what we put in the syringe.
Yeah, you're drawing up your local, and you want to manipulate its onset and duration. First up is sodium bicarbonate.
Right, because by adding bicarb, you raise the pH of the acidic anesthetic solution closer to physiologic levels.
Which increases the unionized fraction of the anesthetic, so it penetrates the lipid nerve membrane much faster. Clinically, this means a significantly faster onset of action.
And a drastic reduction in the burning sensation during the injection.
Yeah, it's an inexpensive, highly effective trick that drastically improves the experience for an awake patient.
But the most intensely debated additive in hand surgery is definitely epinephrine.
Oh, without a doubt. By leveraging the alpha-1 receptor vasoconstriction of epinephrine, usually mixed at 1 to 200,000, you limit systemic vascular absorption.
Which traps the local anesthetic at the target site, allowing you to push your maximum safe systemic dose higher.
And simultaneously doubling the duration of the block.
Okay, wait. We need to address the elephant in the room here. We've had no epinephrine digits drilled into our heads since day one of training.
I know, everyone has.
Are you saying we can completely ignore a century of surgical teaching? That the terminal and artery circulation won't just undergo catastrophic vasospasm and necrosis?
I am saying exactly that. If you rigorously analyze the source of that dogma, it completely falls apart.
Really? Because those old horror stories of finger necrosis are legendary.
They are, but they're based on case reports mostly from the 1920s to the 1950s. And those cases didn't fail because of epinephrine. They failed because they were using older, highly toxic anesthetics like procaine and cocaine.
Ah, and procaine was inherently acidic, right? Often
Yep.
stored in multi-dose vials that degraded over time.
Exactly. They degraded into toxic byproducts. You combine that acidic chemical burn with tight mechanical tourniquets left on for hours,
Yeah.
and yeah, you get necrosis.
Wow. That is a massive paradigm shift. We've been governing modern ORs based on flawed 70-year-old data involving degraded procaine.
Yeah, the modern evidence clearly demonstrates that epinephrine can be safely used in the fingers.
Huh.
It provides an incredibly dry hemostatic field for complex digital dissections.
And buys you hours of post-operative pain control without a tourniquet. But, as a surgeon, you always want a bailout protocol.
Of course, if you inject epinephrine, finish your case, and the reperfusion is severely delayed, like the finger's stark white, well beyond your comfort zone in recovery, you have a reversal agent.
You locally inject 0.5% phentolamine mesylate.
Right. Phentolamine is a potent alpha-1 receptor antagonist. It directly blocks the epinephrine, reverses the vasospasm, and hyperperfuses those digital vessels.
The only caveat is that it has a relatively short half-life.
Yeah, you have to monitor the digit. If the vasospasm outlasts the phentolamine, you'll need to repeat the injection. But the rescue pathway is highly reliable.
All right, so with pharmacology dialed in, let's map out the physical anatomy, starting proximal at the brachial plexus and moving down. But first, workflow.
Here's the key point for managing your OR efficiency. Brachial plexus blocks are not instantaneous.
Right, they take 5 to 10 minutes of meticulous ultrasound-guided needlework.
Plus a mandatory 15 to 25 minutes of dwell time to set up for dense surgical anesthesia.
You're basically trading 20 to 30 minutes of prep time for a patient who wakes up pain-free, doesn't need high-dose opioids, and skips the PCU.
Exactly. But you absolutely cannot burn that 30 minutes while the patient is physically on your operating table. Doing so destroys your daily case volume.
So the best practice is a dedicated block room. Anesthesia does the block 30 minutes prior to wheels in while you're closing the skin on your previous case.
You got it.
Mhm.
The patient rolls into your room completely numb, and you make incision immediately.
Perfect. So looking at the approaches, we start highest in the neck with the interscalene block, targeting the roots and trunks between the anterior and middle scalene muscles.
That's the premier block for shoulder and proximal humerus surgery. Because you're high in the neck, your needle stays well away from the dome of the pleura.
Keeping pneumothorax risk very low. But there's a pitfall, right?
Yeah, the interscalene approach consistently fails to anesthetize the inferior trunk C8 and T1. Clinically, this means you will completely miss the ulnar nerve.
So if you try to use it for an ulnar nerve transposition, the patient is going to feel every instrument on the medial side of their arm.
Exactly. To capture the entire arm, you have to move slightly distal to the supraclavicular block,
Yeah.
often called the spinal of the arm.
Because the trunks and divisions are tightly bundled, just superior and posterior to the subclavian artery, it's incredibly rapid and dense.
It is, but the risk profile changes drastically. You're working right over the first rib and the pleural dome. Pneumothorax risk hovers between 0.5 and 6%.
In real life, that's a terrible choice for a tall, thin patient with hyperinflated high lung apices, or a morbidly obese patient where your ultrasound landmarks are degraded.
Right. And because of the fascial planes, the anesthetic will almost certainly spread to paralyze the phrenic nerve.
Causing temporary hemidiophlegmatic paralysis, you'll also routinely block the recurrent laryngeal nerve.
And cause a transient ptosis and meiosis from blocking the cervical sympathetic chain.
Right, just like you have to be fully aware of causing a temporary ptosis during facial procedures, you have to respect collateral anatomy in the neck.
Paralyzing a hemodiaphragm in a healthy 20-year-old is a minor inconvenience. Doing it in an 80-year-old with severe COPD is a respiratory disaster.
Absolutely. So if they can't tolerate a paralyzed phrenic nerve, you're forced below the clavicle to the infraclavicular block.
Targeting the cords around the axillary artery. It's perfect for anything from the elbow down and spares the phrenic nerve.
But the anatomy is unforgiving. It's deep. The needle trajectory is steep, making it super painful for an awake patient.
And the major nightmare is the vascular bundle. If you hit the axillary artery or vein and start a hematoma, you physically cannot hold direct pressure on that bleeding source.
Because the clavicle is in the way, you just watch the hematoma expand on the ultrasound screen.
Which is a universally horrible feeling.
Exactly why many surgeons prefer the axillary block. It's safe, superficial, and you can hold direct pressure if you hit the artery.
Right, often done transarterially. But the pitfall there involves the musculocutaneous nerve. It exits high into the coracobrachialis.
So if you just flood the perivascular space, you miss it, and the patient won't be able to tolerate the ischemic pain of your upper arm tourniquet.
Exactly. You need a separate targeted injection for it.
Okay, but what if a plexus block is overkill, or the block room is backed up? You can bypass nerves and use the venous system instead. The Bier block.
Yes, intravenous regional anesthesia. The physics are fascinating. You exsanguinate the arm, inflate a tourniquet, and inject local PEG directly into the venous system.
Utilizing retrograde flow to push anesthetic backward to the peripheral nerve endings, it's great for cases under 60 minutes.
Or 90 if you use a dual tourniquet system.
Right.
But the margin for mechanical error is 0.
Right. The tourniquet is literally the only thing standing between a numb hand and a massive grand mal seizure.
If that cuff drops prematurely, it dumps a massive bolus of lidocaine straight into the central circulation.
So how do we deflate it safely?
Managing deflation is critical. The tourniquet must remain inflated for an absolute minimum of 30 minutes from the exact time of injection. Even if your carpal tunnel release only took 12 minutes.
You do not drop that cuff. It needs that time for tissue binding.
Right. And when you do deflate, you have to cycle down, drop the pressure, wait 10 seconds, rapidly reinflate. Repeat for 3 to 4 cycles.
It acts like a pressure release valve, washing the unbound anesthetic into the systemic circulation in small waves.
And you must be actively talking to the patient during this.
Yeah.
Ask if their ears are ringing or if they taste pennies. If they do, reinflate immediately and wait.
Okay, moving away from the major vascular approaches, let's trace the distal blocks from the elbow down. Sometimes you just need targeted regional anesthesia.
Starting at the elbow, the ulnar nerve is accessible at the cubital tunnel. But the absolute rule is volumetric control. You inject subcutaneously, superficial to the groove.
Right, never deep into the tight groove itself. You'll spike the pressure and risk intraneural injection. What about the median nerve?
The primary landmark is the brachial artery pulse. The median sits just medial or ulnar to the artery.
So vascular proximity is the pitfall, aspirate repeatedly, and the radial nerve.
It's challenging at the elbow due to high branching variability. It's much more predictable to block it 4 to 5 centimeters proximal to the lateral epicondyle in the spiral groove.
Using the humeral shaft as a backstop, smart. Moving to the wrist, it's more superficial. Ulnar nerve is tucked deep to the FCU. Median is ulnar to palmaris longus.
Just don't forget the palmar cutaneous branch of the median nerve. It's entirely superficial to the fascia.
If you miss it, the base of the palm will remain exquisitely sensitive. And radial sensory is just a wide subcutaneous infiltration over the radial aspect.
Exactly. Finally, we arrive at the digits. This is where we see the most outdated dogma in practice.
Oh, yeah. In real life, we see people doing 2 painful dorsal web space injections, the traditional digital block, when the data says a single volar sub-Q injection is better.
The data is unequivocal. A single volar subcutaneous injection at the base of the digit provides the most rapid onset.
Because the volar fat pad is compliant, it hurts less, whereas the transthecal block driving a needle into a tight flexor sheath is incredibly painful.
The single volar sub-Q is the absolute winner. The only caveat is it misses the dorsal branches, so you'll need a dorsal wheel for anything proximal to the DIP joint.
Makes sense. So, to wrap up our takeaways, never block heavily sedated patients, epi in the finger is safe and effective, cycle your Bier blocks, and embrace the single sub-Q digital block.
Spot on. But before we go, I want to bring up the immediate post-operative period. The massive downside of a great regional block is the midnight pain rebound.
Oh, man, yeah, the 2 a.m. crisis we talked about at the start.
Right. You perform a flawless infraclavicular block. Patient goes home feeling fantastic. Then at 2 a.m., the bupivacaine metabolizes. They go from insensate to 10 out of 10 pain in minutes without any oral meds on board.
So how do you bridge that gap?
Proactive patient education. You have to convince a patient who is currently in 0 pain to set an alarm and take their oral narcotics while their arm is still completely dead.
That's a huge behavioral challenge, but it's just as critical as your needle placement. Definitely something for you, our listeners, to think about as you structure your discharge counseling. Keeping them comfortable in their own bed is the true final step of a successful block.
Absolutely.
Well, that's all for today's deep dive. Stay safe out there.